Hi everyone. How are you all doing? I hope you're enjoying your Christmas break. My name is Mariver Muniz, and I'm one of the instructors in level 3, and specifically OBPD nursing. The number is RNSG 2260. So remember this, RNSG 2260, and that is your OBPD um, simulation and clinicals. Now, if you happen to be in the theory of OBPD, then the course is RNSG 1412. Again, let me repeat this. For theory, the course number is RNSG 1412. For clinicals and simulation, RNSG 2260. My specialty is actually mental health, but since I also have experience with the neonates for 17 years, I was employed in one of the facilities in South Texas Health System, and that is McAllen Medical Center, and I was able to work for 17 years, a combination in neonatal intensive care unit, in intermediate care nursery, which is a step down NICU, and pediatric floor. So, and to give you a very brief background of my education, I finished my bachelor's degree in nursing in in the year 1990s. So I'm not going to tell you how many years was am I, how many years am I being a nurse? I mean, I just, let you figure the math. Okay. Sorry to give you such a math problem, but then so I uh, I had my master's after finishing my bachelor's degree. I was a nurse volunteer in the um, um, in the hospital for a year. It was a Seventh-day Adventist hospital, and then after that, I moved to a local hospital back in the Philippines. And that was a very challenging experience for me, being a new grad, and it was totally different. What do you call this, adjustment? Because when you were a student, you were taught the ideal thing, and then when you go work, it's kind of like a little bit different, adjustment. And we were being taught in school to be flexible and resilient. So yeah, well, I made it. And then after that, after gaining some bedside experience, I was teaching over there in the BSN program for 10 long years. And after that, I decided to come over. I got called in to work in the US over here. And so I started my humble beginnings in Oklahoma, and then I moved to here in South Texas Health System. Oh no, I'm sorry, like RGV. I'm sorry, RGV. So my some of my friends told me, hey, why don't you come over here, because they're offering, sign-on bonuses and this much. So, you know, you want to work as an RN, because back in Oklahoma I was working as a CNA. So I feel for the CNAs, because I know their job is really hard, because I was once in the shoes. I was a CNA, and it's not really an easy task. And so I moved down here, and I fell in love with the place, especially the food. So, and the culture also is kind of like close to the Filipino culture, wherein it's very family oriented. Okay, so I'm married. I'm happily married with two kids. My husband is from the Valley, very, very nice husband, very, very responsible. So I'm so happy. I got married, um, at a not so young age, but my husband is worth the wait. So okay, so story of my life. So let us go to business. So like I graduated 1998 for my master's degree over there in the Philippines too, and my specialty is really mental health. And at the time, I was like, hey, why not mental health? Because a lot of nurses were, wanting to specialize in medical surgical nursing, and there was not any faculty over there whose specialization is mental health nursing. And I said, I told myself, why not mental health nursing? You could use some principles of mental health nursing, like for example, therapeutic communication techniques in dealing with medical surgical patients, in dealing with, you know, um, OB patients. We have some moms that go into postpartum depression, and you could use those therapeutic communication techniques. Okay, so since we are in OBPD level 3, so I had an extensive experience, bedside experience in neonatal intensive care and step down neonatal intensive care. So maybe one of you wants to be a neonatal nurse one day, and it's very, very challenging. One good thing is you don't have to lift a patient. Your patient is so light, you could handle it, but then it is an art because your patient doesn't tell you, your little patient doesn't tell you, I'm in pain, I'm in so much discomfort and all these things. So all you have to do is assessment is very, very important. If the baby is crying, what does that mean? Is the baby hungry? Is the baby in pain? So, or is the baby wet? Do you need to change the diaper? So it is very, very challenging. Okay, just to give you a heads up on how to and how to cope up when you want to be a neonatal nurse. So when I used to work in one of the hospitals, we're getting floated to regular newborn nursery, and also, well, in the main neonatal intensive care, we're in U level 3 babies. What do I mean by level 3? Like they have higher acuity. They're very, very sick babies. So which means they need ventilatory support. Like they need breathing machines, all those tubes. And assessment is very important. Every 2 hours assessment, sometimes it's every hour, especially if the baby is very, very sick. Okay, so without further ado, these are just to give you some, a little bit of idea on how to deal with newborns. So it all comes up to the very first, the very first thing when they are born. Uh, whenever a mom delivers, you are going to assign a score, especially if you are the baby catcher. So you call that score APGAR scoring. Okay, so let me share you the file. What is APGAR scoring? So let me share you this. Um, I'm sorry, my internet is kind of slow, but if you want to wait a little bit. Okay, so it's loading down. This is the APGAR scoring. So, okay, what is really APGAR scoring? So it is named after a doctor named Virginia Apgar, and it stands for, it's an acronym. Right? So A means appearance, P means pulse rate or heart rate. G means grimace or reflex irritability. A means activity or muscle tone. R means respiration. So the moment the baby comes out from the vaginal canal, baby's being out, baby catcher, the doctor will sign an upper score. So appearance means what's the color of the baby? Is the baby pinkish? Is the baby bluish? Is the whole body pinkish but the extremities bluish? Then you're gonna have to assign a score. P means heart rate. You auscultate the baby's heart rate in 1 full minute, and then you assign a score. How about the baby's grimace? Is the baby crying or the baby's not crying? Then you assign a score. Activity. What is the muscle tone of the baby? Are the baby's extremities flexed or not? So then you have to assign a score. And then respiration. Is the baby breathing really well? Or the baby needs support because the baby is grunting. Grunting means baby makes some weird sounds, So then you will have to score. I will now you will have this later on, but this is just to give you a background information of what it is, an idea. So then you have to give a score, and then you total the score, and any 0 to 3, this is critically low, so that means that your baby needs resuscitation. The baby really needs to be brought to the NICU right away. The baby needs to be resuscitated, and the baby needs ventilatory support here. Like it has to have a breathing tube, for example, start an IV line, connect the baby to a ventilator machine, or another form of machine that will help the baby breathe. Then after scores of 4 to 6, it's low normal. They also require ventilatory support. Most likely, of course, they will need some form of breathing tube or a cannula, which delivers high pressure of oxygen so that the lungs will expand and the baby can breathe very well. After scores of 7 and up are considered normal. So usually when you are in the NICU or into step down NICU or in the normal newborn nursery, if the nurse or the baby catcher tells you, I'm giving you a baby, you're going to admit the baby after a score of 9 and 9, then that baby automatically goes to, if you don't hear any abnormal sounds, then the baby goes to the regular newborn nursery. So it's like, you might want to ask me, what is the difference if the baby goes to a regular newborn nursery or goes to a step down NICU? Okay, so when the baby goes to a regular newborn nursery, the baby is not attached to a monitor or cardiac monitor. The baby is placed in a crib, regular open crib. But if the baby has some issues, the upper score is below 7, that baby's gonna land in an ICU or land in intermediate care nursery, depending on the size of the baby. Micro preemie babies or teeny babies, they immediately land in an ICU because they need some help in breathing. Okay, so there's as far as upper score. Okay, if I'm gonna show you a picture of this, and I want you to, okay, let me show you another picture. Okay, so this is a baby being born. Okay, so what do you think is the score or Apgar score of this baby? See the baby's crying, facial grimace, baby's pinkish. By the look of the baby's face, the baby is really crying. Oh my gosh, the color is very good. So you could assign an Apgar score there of 9 and 9. Right? 1 minute, and then after 2 minutes, and then after 5 minutes. So usually the nurse, the baby catcher, will tell you 9 and 9, 1 minute and 2 minutes. So 9 and 9. This is a 9 and 9. That means 9 after 1 minute and 9 after 2 minutes. Okay, how about this one? What is the score of this baby, of this kiddo here? Okay. All right. So see, baby's frowning. Looks like the baby's telling you, why did you pull me out from that comfortable cave, you know? So see the color? He's frowning, he's not even crying. The color you could see, it's kind of bluish, the baby's cyanotic, so you can assign a score there. Although the extremities are flexed, but the color is not good. So if you are the baby catcher, you can ask if you're the baby catcher, you're gonna assign a score on this. Maybe you wanna assign a Apgars of 6, and then later on, if the color turns pinkish, then maybe after 2 minutes, you could give an 8. Depend. It really depends, on the situation. Okay, so let me show you another photo. This is what you call the Ballard scoring or Dubowitz. Okay, so let me kind of where's the chat here? Let me show you the Ballard scoring. Or you could you call some nurses would call it Dubowitz scoring. So what is this all about? So the moment you get a baby from labor and delivery, whether a very, very sick baby or a normal baby, a preemie baby or a normal one, which is full term, 37 and above is full term, below 37 is considered preterm. Okay, so there are two components of your Ballard scoring or Dubowitz scoring, and this is the neuromuscular maturity and then the physical maturity. So each is being scored. Like, for example, when you receive the baby, what is the baby's posture? Then you're gonna assign points. You're gonna assign score. If you see that the baby is this kind of posture is this, then you assign 3 in this aspect. Square window. If your score is 4, then you put 4. Arm recoil. This one, then assign a score here. So score. Say for example, if it's 2, then you put 2 here, and so forth and so on. And then you add what is your score in posture? What is the score in square window? What is the score in arm recoil? How about popliteal angle? What is your score? And then scarf sign, what is your score? Heel to ear, what is your score here? Then you add. Then after that, you go to the physical maturity. So what is physical maturity here? You see the skin. Is the skin cracking? Is there deep cracking? This is very, very common, parchment deep cracking, very common among, or leathery appearance, very common among postterm babies, uh, how about lanugo? Lanugo are hairs at the baby's back of the neck, and also you could find the lanugo on the ears. Okay, so then you're gonna assign a score. Is it balding, or there's like a lot of lanugo? So the more lanugo, the more preemie the baby is, the more lanugo. Okay, mature babies or full-term babies, they are mostly bald, or post-mature are mostly bald. How about the plantar surface? This one is very, very indicative. If the baby's premature or full-term or post-mature, you see the creases on the plantar surface, on the foot. Like on the plantar surface, the foot, you see the foot, like there's a lot of creases, there's a lot of lines there. And if there are less lines, it tells you lesser lines are more indicative of prematurity. But if there's a lot of lines, call it creases, then the more the mature the baby is. And the breast also, you feel the areola, kind of squeeze the areola, and then you assign a score. If it's 3 to 4 mm, you're gonna estimate it. If it's you feel like it's 3 to 4 mm, then the score here is 3. If you feel the areola is not full, anterior transfer areola, stippled areola 1 to 2, then what is the score here? Then maybe 2. So you put a score and so forth and so on. And if it's a male baby, of course, you're gonna have to just do kind of find out all what score do you have. But if it's a female, you don't need to fill this one out. So whatever your score here, you add, and then after that, what is your total score for neuromuscular maturity? And what is your total score for physical maturity? If the score is 35, it's here. So maturity rating score is, let me enlarge this. Oh, I think, okay, it makes the picture. Okay, let me just do this. Okay, so if your score is 35, so then you see how much is the in weeks. So therefore the baby is, what is this, 38 weeks. So the baby, therefore, if the total score, which is neuromuscular maturity score or grade plus the physical maturity score or grade totals 35, then the baby is a 38 weeker. So therefore, when you go to the area and you hear the nurses give report, the nurses would say 37 days by, by dates. That is basing on the month's last menstrual period, and 38 weeks by gestation. Okay, gestation, which means by basing on the Ballard scoring. So therefore, if it's 38 weeks, then the baby is full term. Okay, but if your score falls 25 here, and then it tells you the maturity rating is 34, then the baby is premature. 25 weeks 34 weeks by gestation or by exam. Like say, some nurses would say 34 weeks by exam, 34 weeks by dates. So you might get confused. What do you mean by date? So that means they're basing on the mom's LMP or last menstrual period. It's the first day of the last menstrual period. Okay. So those are some of the stuff that you could see in the clinical area, and we as beginners, we are given the chance to do this in the clinical area, and I would really, really want you to do this when we have a baby coming from labor and delivery and admitted to the newborn nursery. Not so much with NICU. Probably I will let you observe, but then for in the regular newborn nursery, I will let you do it. Okay, so let me stop sharing this. Okay, so as far as for your clinicals, we will be for the level 3. We will be very, very particular on the professional appearance. Also, I'd like to give you a heads up on that. We will randomly check the uniform. Are you compliant with it? And attendance also is very, very important. There will be another orientation probably on the first day. Of course, the first day starts with orientation of your clinicals and another orientation for your theory. Okay, all right. So I hope I have given you some Important tips to know and what to do. You're going to be in the clinical area. You will also be assigned in the postpartum unit and also the labor and delivery. And do you know that if you want to work one day in the neonatal intensive care or in the regular newborn nursery or in step down neonatal intensive care, or this is what you call intermediate care nursery, moms data or information is also very, very important. Mhm. If the nurse or if the baby catcher tells you mom is having gestational diabetes mellitus, then that gives you first-hand information that this baby is gonna be, it's gonna be sick, and you're gonna have to insert an IV line on this baby because one of the complications that the baby would have is hypoglycemia. And you don't want a baby who is hypoglycemic, a baby whose sugar is below 40. That entails you have to bump up that sugar, otherwise there will be serious complications. And another thing too is, don't let the baby. You have to put the baby in the warmer right away because, especially if it's fresh from labor and delivery, especially delivered, because you don't want a cold baby. A cold baby of if the baby is placed in a cold environment, baby is going to be prone to infection and at the same time also hypoglycemia. So it's a very interesting, OBPD, neonatal care is a very interesting specialty. And I hope one day, you will be encouraged to work there also because it is really an art. And assessment is really very, very important. Okay. All right. So please, when you are in theory or in the classroom, which is RNSG 1412, or in clinicals or simulation RNSG 2260, please observe proper professional appearance, okay, uniform. So it is there in the handbook. It is there in your ADN handbook. Please, please, please read it because we will check randomly uniform. We're very strict about it. So good luck, everyone, and we'll see you in the spring semester. And please enjoy the holidays and start reading. Start reading. We, especially in theory, it is very, very important for you guys to pre-read the topics, pre-read the chapters. If it's there in your blackboard, pre-read the topics because it is very, very important that a little bit of the topic that's going to be discussed. Because if you don't read anything, then you will be having a hard time, understanding the concepts. All right. Okay, I guess that will be it. Bye bye, everyone. And Merry Christmas and Happy New Year to all of you. Bye for now.